one other that's kind of important to talk about, I think, is nitric oxide as well. It's one that gets talked about a lot in the setting of methylene blue because nitric oxide itself is very, very important. There's different types of nitric oxide. There's nitric oxide that's very important for our blood vascular wall, which keeps our vascular system healthy, our heart healthy. There's nitric oxide that's in our mitochondria that helps with energy production. There's nitric oxide in our brain as well that helps with energy production, detoxification. Excuse me. And so one of the things that's pretty well known is that methylene blue does have an effect on nitric oxide. But what's not well known is what that effect exactly is. And so I'll tell you how I use it first, and I'll tell you why. At higher doses of methylene blue, like about a milligram and a half, so like 50 to 70 milligrams or above, I'm typically using nitric oxide support at the same time as a preventative, potentially, to the decrease in nitric oxide that may happen at higher doses of methylene blue endogenously. Endogenous nitric oxide is a type of nitric oxide that's released in the mitochondria and the vascular walls, okay? When it comes down to looking at lower doses of methylene blue, I don't typically use nitric oxide as a support, and this is why. There's a different type of nitric oxide that we really care about. There's the endogenous supply that comes from the vascular walls, from the mitochondria, but there's what's called inducible supply of nitric oxide. This is a type of nitric oxide that's released when you have infection, inflammation, severe stress. And this is a circulating type of nitric oxide that's released and causes pain, inflammation, inflammatory cascades, and it causes low blood pressure as well. So this is the type of nitric oxide that's important at low doses, but oftentimes is vastly dysregulated in people with chronic complex medical illness, or they have low blood pressure, like POTS, for example, is a very common disorder where you have positional hypotension, you have orthostatic issues, you have tachycardia, so you can't maintain your blood pressure, you have high heart rates. So this is a condition where you have a lot of inducible nitric oxide floating around. All doses of methylene blue, whether it be low doses of methylene blue or high doses, have a neutralization effect on the inducible supply of nitric oxide. This is a good thing, okay? Because you have less inducible nitric oxide around, you have less pain, less inflammation, less low blood pressure, okay? So this is a good thing. Now, higher doses of methylene blue will have an effect on that inducible supply, and they may have an effect on that endogenous supply as well. That's in your mitochondria, in the vascular walls. But the lower doses will not have this effect, okay? So that's why lower doses of methylene blue it's not required to take nitric oxide with it because you're not having an effect on that endogenous supply. So maybe in summary, because I don't want to confuse people, is that endogenous nitric oxide supply is not affected by low doses of methylene blue. Higher doses of methylene blue will potentially have an effect on that endogenous supply. So as a result of that, it's important to think about using nitric oxide in combination. So if we have patients that are on higher doses of methylene blue for chronic infection, for example, I will be giving them nitric oxide as a supplement in combination. But the low doses of methylene blue will not have an effect on the endogenous supply. And as a result, I don't think about having to use it. If they do have an effect, it's going to be on the inducible supply, which is actually a good thing because it's going to neutralize the inflammatory and pain cascades that happen because of inducible nitric oxide around for a long period of time.
Got it. Really important. I definitely wanted to go here. So just to be crystal clear, what kind of dosage wise are we talking when you'd want to start including supplementing with NO?
I typically start anywhere above around 30 milligrams or so, just to be absolutely conservative about it. The data, when I looked at it recently again, there really is no evidence that you have a major effect on endogenous nitric oxide supply until you get to around about 2 milligrams per kilogram orally. If you're taking IV methylene blue, that's different. Not something that I'm as familiar with, but certainly above a milligram per kilogram. So just for numbers for people, we're talking anywhere between 50 to 70 milligrams to 150 milligrams of methylene blue. So 50 to 70 is about a milligram per kilogram, and 2 milligrams per kilogram is about 150 milligrams. So the major studies out there really don't show any major effect on endogenous supply until you get to about 2 milligrams per kilogram orally. But to be as conservative as possible, I typically will start adding in NO in protocols when somebody's about 30 milligrams or above methylene blue, taking it regularly. If they're taking it at a less of a dose than that, somewhere between anything less than 30 milligrams, I'm typically not using endogenous oral NO to support them.
And say you're fighting an infection and it's just a temporary use of 30 plus milligrams, say 2-3 days. Are you going to worry about NO?
Absolutely not, actually. In this case, you're not going to worry about it because you want there to be inducible supply that's neutralized. And it's okay if there's some of the endogenous supply as well, because it's going to cause some vasoconstriction. It's going to cause a little bit of mitochondrial stress that's actually going to be beneficial to treat the infection. So methylene blue is actually used at these higher doses in very severe cases in septic shock, people with cardiopulmonary arrest, because it can cause a significant amount of vasoconstriction at these higher doses. And so there was a great, fantastical paper that was sent out around the internet about mid 2025, talking about blue brains specifically, and they talked about they showed these autopsies of these patients that had died, obviously, that had gotten very, very high doses of methylene blue, and said, well, if you take methylene blue, you're going to get a blue brain. You shouldn't take methylene blue. These patients were getting very, very high doses of IV methylene blue as a rescue agent, a last-ditch agent to try to save their life. Septic shock, cardiopulmonary arrest, severe other presentations. And they died. They gotten around 300 milligrams of methylene blue IV over about a 3 to 4 hour period. So there's a huge amount of methylene blue and not clinically relevant at all. And for most cases that are going to be outside of from normal waking life here, right? These are people that there are no other choices. They're trying to save their life, right? And so these patients, when they did the autopsies, a couple hours after they died, had blue brains, which is not surprising. That is a huge amount of methylene blue. You taking methylene blue right now between 4 and 25 milligrams, or even to 100 milligrams dosing, this is not going to cause your brain to be blue. Your brain is going to redox cycle the methylene blue, right? It's going from blue to colorless, and eventually it's going to come out of your system. It's not going to stay there. It's going to come out of your kidneys, and you're going to urinate blue. The more methylene blue you've taken, the higher the dose, the longer it's going to stay blue, okay? But it's not going to make your brain blue. It's not going to stain it blue. This was just an autopsy of people that got very, very, very high doses. So in essence, I don't use those high doses at all. And I don't use it IV personally, but I do sometimes use 2 milligrams per kilogram, which is around 150 milligrams of methylene blue. And I'll do that for 3 to 5 days. I've used that for acute viral infections, acute bacterial infections, acute trauma as well. I've used it for things like traumatic brain injuries and concussions. And all of my patients have higher doses of methylene blue in their medicine cabinet just in case they need it. But most of the time they don't need it, but they have it just in case. So I'll have them take 2 milligrams per kilogram if they get an acute injury, if they have an acute infection, they'll do it for 3 to 5 days. And they do well. They do very, very well at those doses. And I don't worry about nitric oxide, but I will worry about it if somebody's on a longer term protocol where they're on 50 or 70 milligrams a day for a period of 7 to 14 days or longer. I am thinking about using nitric oxide support, absolutely, so that we're not depleting it over time. And so that's the nuance there. So and the blue brain thing it was a great clickbait headline as well. And there's really no clinical relevance to it that nobody has to worry about getting or having a blue brain when you're taking methylene blue, especially at doses that we're talking about here, super low doses.
Since you made it to the end of this clip, I know you're going to love the full episode. Click here to watch. I'll see you over there.
94% of US adults have mitochondrial dysfunction. I see this on an everyday basis in my clinical practice, where we start low doses of methylene blue and see fantastic benefit across the board, anything from pain, inflammation.